Okay, so I'm going to present a summary of the pharmacotherapy workup plan that I created for our patient Clay. Our patient Clay is a 70-year-old Caucasian male who weighs 138 pounds and presented to the ER approximately 4 hours ago after his daughter called 911 when she found him with a high fever, greater confusion than baseline, and inability to get out of bed. He has no current history of present illness. His medical conditions include dementia, which he has been diagnosed with in 2015, and hypertension, for which the date of diagnosis is not known. His current home medications have been collected from his community pharmacy, and they include cisalopram 5 milligrams by mouth daily and hydrochlorothiazide 12.5 milligrams by mouth daily. He takes this in a combination tablet for his hypertension. He also takes rivastigmine 3 milligrams by mouth twice daily for his dementia. And other home meds include aspirin 81 milligrams by mouth daily, vitamin E 400 units by mouth daily, vitamin C 500 milligrams by mouth daily, and vitamin D 1000 units by mouth daily. He takes these medications in a blister pack. No compliance issues have been identified. His current status in hospital: he has been since admitted into general medicine under Dr. Kauteki. Diagnostics have been performed. Foley was inserted and collected 100 cc's of urine, which was dark and amber in color. The urinalysis came back and provided the following results. It came back positive for proteins, ketones, leukocytes, and bacteria. Urine and blood cultures are still pending, and upon physical examination it was found that his skin was dry and mouth and tongue were dry. Looking at the blood work, the patient's electrolytes were slightly elevated, specifically his sodium and potassium, but not too high above normal limits. We also see an elevation in his BUN, which is currently 16.9, and we see a slight reduction in his calcium and magnesium. Overall, his physical findings and his blood work indicate that he's slightly dehydrated. Upon admission, he has been reordered on the following meds. He has been started on dextrose 5 and 1/2 normal saline solution at 100 cc's every hour IV for rehydration. He has dalteparin 5,000 units subcutaneously once daily for DVT prophylaxis. He has been restarted on his home meds, but has a hold on cisalopram and hydrochlorothiazide because his blood pressure is below baseline. His daughter states his baseline is usually 140/80. Currently, his blood pressure is at 110/70. He has been administered acetaminophen 325 milligrams PR, which brought down his temperature to 37.8, which is within normal limits. Looking at his respiratory rate and oxygen saturation, heart rate, these are all within normal limits, and the patient is currently hemodynamically stable. He's been found to be slightly constipated upon examination and has been administered a glycerin suppository, has an enema ordered, and he has also doxycycline sodium by-mouth BID ordered, senicide 8.6 milligrams for nighttime dosing ordered, and an antibiotic of centriaxone 1 gram IV administered every 12 hours for his current infection. He has been deemed NPO until seen by speech-language pathologist. Of the current medications that he has been ordered upon admission, I have identified one drug therapy problem that I believe is pertinent to his current goals of therapy. I'm going to list his goals of therapy now. The goals of therapy that I have created for our patient include resolution of the patient's current infection and other related symptoms. We want to prevent reinfection, and we want to remove the patient's risk of developing a worsening infection by not treating it, and we want to minimize the patient's antimicrobial burden by choosing an appropriate empiric agent that is likely to kill the pathogen, but also reduce the risk of secondary issues like C. diff by choosing the least broad-spectrum antibiotic that we can. The drug therapy problem that I have identified is as follows. The patient is at risk of experiencing ceftriaxone-related complications and side effects like calcium precipitation and subsequent renal injury, secondary to receiving high dose of ceftriaxone. This is anything that's 2 grams or greater within 24 hours, and I believe he would benefit from therapy modification. Looking at our alternatives to the current order, we can switch the ceftriaxone to 1 gram IV every 24 hours. I believe this is safe and effective and has a lower risk of renal injury. Another alternative would be to start him on an aminoglycoside, like gentamicin, 3 milligrams per kilogram per day, and ampicillin, if we were worried about gram-positive bacteria like enterococci. However, I believe this is not appropriate because the patient is not in a critical state. He's hemodynamically stable, and therefore this would have higher risks than benefits, because using an aminoglycoside has more risk of toxicities like nephrotoxicity, which we are worried about in our patient. My plan is to change the ceftriaxone to 1 gram IV every 24 hours and administer this for 5 days and then reassess. I want to change the patient to PO ceftriaxone once the patient is no longer NPO status. I want to discontinue all IV medication and hydration once the patient is NPO as well, and reevaluate the appropriateness of the current antimicrobial therapy once culture results come in. The daughter and patient should also be offered social work support to discuss preventative strategies for minimizing future infections. The discussion should include taking briefs more frequently and staying hydrated. In terms of follow-up and monitoring plan, we want to monitor the injection site upon every dose, to look for swelling, redness, and heat, monitor for signs of hypersensitivity like rash and itching upon the first dose, approximately 1 hour after, and monitor for signs and symptoms of C. diff 1 to 3 months after therapy. In terms of efficacy monitoring, we want to see signs of improvement and signs and symptoms of infection, like reduction in fever and improvement in cognitive status, and within 24 to 48 hours. We also want to continue to monitor his vital signs for signs to make sure he remains hemodynamically stable. Please let me know if you have any questions. Thank you.